Hello everyone, I am Enriqueta Felip, medical oncologist at the Vall d'Hebron University Hospital and the head of the Vall d'Hebron Institute of Oncology's Thoracic Tumors Group in Barcelona, Spain. And today I am joined by Professor Keith Kerr, consultant pathologist at the Aberdeen University Medical School and Aberdeen Royal Infirmary in the UK. So together we are going to discuss the exciting topic of HER2 testing and HER2 targeted treatments in non-small cell lung cancer. So three relevant points in the agenda today: the activating HER2 alterations in non-small cell lung cancer. The second one is the testing for HER2 alterations in non-small cell lung cancer. And finally, the HER2 targeted agents in patients with non-small cell lung cancer and HER2 alterations. So let's start with activating HER2 alterations in non-small cell lung cancer. So HER2, I think we can discuss, but is an oncogenic driver alteration that mediates the carcinogenic process in non-small cell lung cancer. HER2 is a tyrosine kinase receptor from the ERB family. HER2 has no known ligand, and HER2 is activated via heterodimerization with other HER family receptors or homodimerization. The next step is the activation of downstream signaling pathways, RAS, RAF, MEK, ERK, and PI3K, AKT, mTOR, and JAK-STAT pathways. And these regulate the cell processes, including proliferation, survival, differentiation, and migration. So overall, HER2 alterations that upregulate its activity contribute to carcinogenesis and tumor progression in non-small cell lung cancer. So overall, when we focus in patients with non-small cell lung cancer, we can see HER2 mutations in approximately 1 to 4% of the patients, mainly in adenocarcinoma tumors. Also, we can see HER2 overexpression in 2 to 30% of all tumor tissues from lung cancer patients, and also HER2 amplification, 2 to 5% of the cases in de novo tumors, but also as a mechanism of acquired resistance in patients with EGFR mutation and resistant to EGFR TKI third-generation agents. So today we are going to discuss some of the questions submitted by our audience relating to HER2 alterations in non-small cell lung cancer. And Keith, the first one: how do the different HER2 alterations impact in the prognosis of patients with non-small cell lung cancer?
Thanks, Enriqueta. So this question always comes up when we're thinking about molecular alterations in lung cancer as potential targets for therapy. We have to think about the biology of the target as well. And I think it's also fair to say that we don't have a lot of information in this particular arena, and it's complicated because we've got three separate types of alteration. We've got the commoner overexpression of the protein, but then we've also got uncommon gene amplification and uncommon gene mutation. And that does alter the data landscape for what we have available. A meta-analysis some years ago looked at the prognostic implications of overexpression of HER2 protein and came to the conclusion that probably it was a poorer prognostic factor, taking into account all of the confounders and all of the variability that there was around all of the studies that were included. And this probably marries in with observations that HER2 positive lung cancers tend to be a bit higher grade histologically. In that same study, HER2 amplification did not appear to be a compelling poor prognostic factor. Data didn't support either way. When it comes to mutations, we don't have very much data at all to rely upon. There is a suggestion that perhaps HER2 mutated lung cancer has more brain metastases, possibly more pleural disease involvement, so a hint again at more aggressive disease, but it's very confounded by a number of issues, including the presence or absence of suitable therapy for our patients. So overall, the question is rather ambiguous, with a hint that overexpressing cases might be more aggressive.
Yeah. But you mentioned, no, we have 3 different alterations in HER2, so it's a heterogeneous situation. So
Yep.
from more biological point of view, how can we target the HER2 alterations in non-small cell lung cancer?
Yeah, we've got a number of things to think about here. We've got three different alterations from a molecular perspective, and unlike in other tumor types like in breast or gastric cancer, to a large extent, these alterations are not related to each other in any significant way. So we're probably talking about 3 separate groups of patients. Inevitably, when we think about a tyrosine kinase being activated by some oncogenic activity, we think about tyrosine kinase inhibitors as potential ways of going after this particular type of tumor. So kinase inhibitors are certainly things that have been looked at in the past, and as we'll see later, are also going to be pursued going forward. But another very interesting way of leveraging the overexpression of the HER2 protein is to think about antibody-drug conjugates as a way of delivering chemotherapy into the tumor. And certainly the results, again, as we'll see shortly, are really very encouraging in this particular area.
Mm-hmm. Yeah, I think HER2 is a relevant target. No, we need to think these 3 different alterations. There are different treatment approaches, no, but also we have the guidelines, no, that we receive some recommendations from the guidelines. Yeah. What are your thoughts about the recommendations of guidelines regarding HER2 alterations detection in patients with non-small cell lung cancer? So, as you say, guidelines are very important at making recommendations and suggestions for how we approach our treatment for patients with a variety of different oncogenic drivers in advanced stage non-small cell lung cancer. One of the problems with guidelines, of course, is that they are not necessarily up to date in this rapidly changing arena of lung cancer therapy. So whilst we have recommendations for HER2 mutation testing already in all of the guidelines, so HER2 testing for mutations is part of the recommendation in conjunction with the use of next generation sequencing as a way of capturing a broad range of targets that we have to look for in our patients with advanced stage non-small cell lung cancer. Of course, the very recent approval of HER2 targeted antibody drug conjugate, at least by the FDA, for patients who have overexpressed HER2 protein, this is not going to be mentioned in any of the official guidelines at the moment, but as these guidelines are renewed, then I'm sure these recommendations will be included. Yes, so there is overexpression. Also, NGS in general is recommended in patients with non-squamous histology and stage 4 disease. But we have some challenges in the implementation, no, of NGS in some countries. No, I don't know what is your view in Europe, no, about the situation. But yeah, I think it's clear in all the guidelines we need NGS for patients with non-squamous stage 4. But we have still work to do, no, for implementation around all Europe.
Absolutely. From a European perspective, the implementation of next generation sequencing is still, one could say, patchy. I think the situation is improving, but next generation sequencing it's one of the ways that we can achieve the sequencing that we require, as I will discuss later on. But from a practical point of view, it's by far the most efficient and indeed now cost-effective way of delivering the large number of targets, including HER2 mutations, that we need to deliver for our patients. So hopefully, as time passes and as more and more targets are identified, the pressure to deliver HER2 mutation testing in the context of next generation sequencing will increase. I think it's probably appropriate at this point in our conversation to also just mention that HER2 amplification, whilst it does occur in lung cancer, is not the primary target that we are discussing today. I'll mention it briefly later on, but we're talking about mutations and we're talking about protein expression.
Yeah, I think the tumors committee in each institution is key, and also the molecular tumor war, no? to discuss these molecular alterations and also to deeply understand the meaning.
Absolutely, and you know, in the context of the tumor board, official or unofficial, one of the really important things in this area is clarity over which HER2 alteration is being considered or being discussed. So we now have to turn to the very important question of testing for HER2 alterations. And at this point, I just want to repeat the emphasis on understanding that there are three different types of HER2 alteration. There are mutations, most commonly in exon 20 of the gene, where the tyrosine kinase is coded for. There are tumours which have amplification of the HER2 gene, and there are tumours which overexpress HER2 protein. And unlike in the situation with breast cancer and with gastric cancer, for example, the correlation between the alterations, mutation, amplification, and overexpression is not strong. Therefore, we have to really think about these alterations as separate groups of patients, separate types of alteration in patients' tumours. For mutations, the approach that we have to take is that we have to sequence the DNA primarily in order to identify the mutation. And whilst all of the different methodologies that we are familiar historically for looking for mutations, including Sanger sequencing, targeted PCR approaches, next generation sequencing is now by far the preferred approach. When it comes to amplifications, although at the moment not an important clinical alteration that we need to look for in lung cancer, there are different methodologies that we can use for amplification, including quantitative PCR. Next generation sequencing can identify at least a proportion of patients who have HER2 amplification, but probably still the gold standard for HER2 amplification would be FISH testing. For overexpression of the protein, immunohistochemistry is the test methodology that we have to consider.
Thanks, Keith. So now let's comment some questions about HER2 testing in non-small cell lung cancer submitted by our audience. So when should HER2 testing be carried out in patients with non-small cell lung cancer?
Thanks, Enriqueta. So immediately I have to preface my answer to this question by saying yet again, it depends which HER2 abnormality or alteration we need to test for. Primarily, we're going to be thinking about testing for HER2 mutations. So I think that the best approach to HER2 mutation testing is that the HER2 mutations are part of the sequencing package that we deliver on our lung cancer samples. And the best way of doing this is using next generation sequencing. And because many of the alterations that we identify during this next generation sequencing testing are required for first-line treatment decisions, this is the time when we should also think about including looking for HER2 mutations. The data that we get on HER2 mutation prevalence in our patients at this period before patients received any therapy upfront is relevant for a treatment decision in second line.
Yeah, I fully agree. Yeah, sorry, Keith, but I fully agree. As a medical oncologist, we need to have the results the day of the first appointment with our patients with stage 4 disease. I think it's important the reflex testing implemented in this situation of non-squamous stage 4, and we have, yes, we need the panel, the NGS panel, including HER2, before starting any treatment, because this is, I think, important information to discuss with the patient, not only for the first treatment approach, but also for the different potential approaches even in second line. So I fully agree that we need these results, at least HER2 mutations now, before starting any treatment for patients with non-small cell lung cancer. And we have probably in the future HER2 overexpression, no, as we discussed, no?
Absolutely. The HER2 overexpression question in terms of when to test is a little bit more difficult to answer, because at the moment, the therapy in that particular context is a last resort therapy in a sense, and it may be harder to justify looking for that protein expression up front. So it's possible that the HER2 testing might be done further down the patient's treatment journey, but we haven't really decided on what the best approach should be in that particular context.
Yeah. And we have also discussed a little implementation, but I think it's important to discuss here, no? What are the key considerations for implementing HER2 testing in clinical practice, NGS in tumor versus liquid biopsy? What do you think? Tumor, we need biopsy, or we can do even in cytologic material?
Well, remember what we just said, Enriqueta, about this, the HER2 mutation testing being part of the package of testing that we do on our patients. So we have usually only one sample. It's usually a small biopsy sample or a cytology sample, depending on where you work. In Europe, it might be more likely to be a cytology sample or more likely to be a small biopsy sample. But the general rule is that we do not have a lot of material to work with. So, of course, the tissue that we're working with is always an important consideration. And it's very important that the pathology laboratory handles this tissue in a very careful way, bearing in mind that biomarker testing might be required for our patient. So upfront testing, careful handling of the tissue sample that we have, and reflex testing, of course, is much better than a bespoke testing approach, ordering tests according to what the oncologist wants. It's much better if we can reflex test for all of the biomarkers that are required. And I think that our experience tells us that cytology samples, if prepared in an appropriate way, are just as good as small biopsy samples for the purposes of mutation testing.
And another important question from our audience today: how are HER2 testing results interpreted in non-small cell lung cancer? So the interpretation is key, no?
Interpretation is key, and communication is even more key. And we're again back to this issue of which HER2 alteration are we actually speaking about. So clearly, if we are describing a HER2 mutation, we should be describing which HER2 mutation we are reporting, and whether or not we believe this is an activating HER2 mutation. As we mentioned already, the vast majority of the patients, 85–90% of the patients that were included in the clinical trials for HER2 mutant patients had exon 20 insertion mutations. A much smaller proportion of patients had alterations in exon 8 or in exon 19. So clarity over the type of mutation clearly required. When it comes to HER2 protein expression, it's even more complicated, unfortunately, because we are in a position where we're expected to use the immunohistochemistry assays that are actually designed to detect amplified HER2 amplified cases in gastric cancer. So whilst that assay and the way it is read and reported delivering a result of IHC3 plus or IHC2 plus, this has very, very specific meaning in the context of this assay. And to be honest, I think it's questionable whether this truly reflects the amount of protein expression, but this is the assay that has been approved by the FDA as things currently stand. And so that would be the assay that would have to be reported. When it comes to reporting amplification in those rarer situations where this may be an item of interest, it really depends on whether we are reporting a raw figure for gene copy number, in other words, how many copies of the gene are present in the tumour cells, versus whether there is true amplification, whether the assay, and now we're talking about a FISH test, whether the assay is capable of telling us whether the ratio of the chromosome marker versus the number of copies of HER2 on the chromosome is sufficiently increased, and it's usually at a ratio of 2 or more to 1. Is it increased enough for us to say this is amplification? So it's really, really important that there is clarity over the reporting and indeed understanding on the oncologist side, understanding of what is being reported by the lab.
Yeah, so yeah, I think teamwork, clarity and communication are key when interpreting the HER2 results, no? And another question from our audience, what is the potential role for liquid biopsy when determining HER2 status in patients with non-small cell lung cancer?
So the question of liquid biopsy, again, always comes up in the context of these conversations. And liquid biopsy has great potential to deliver an alternative source of molecular data for our patients. It cannot tell us anything about protein expression. That's the first thing that I should say. The second thing that we need to understand about the liquid biopsy is that the success of using liquid biopsy depends very much on how much tumour DNA there actually is shed into the patient's bloodstream. This inevitably means that there will be patients where an alteration is present in the tumour, but there is insufficient shed into the blood for it to be detected. So it's not, I would say, the gold standard best solution under any circumstances, whether you're looking for a mutation like HER2 or you're looking for an amplification. But if you have no alternative, or if you have the possibility of doing a tissue assay and a blood assay, the two can be considered as complementary. But in general, because of the lesser sensitivity, and particularly so for amplifications, which are probably even less efficiently identifiable in tumour DNA, then a tissue sample is certainly preferable, but liquid biopsy is an alternative.
Okay, so overall, no, NGS in tumor tissue is the standard. Liquid biopsy may be considered an alternative, and if it's positive, we can use because it's enough, but in case it's negative and it's the only way, we need to have NGS in tumor tissue because it's more sensitive. No?
So we now need to move to the question of considering HER2 targeted treatments in non-small cell lung cancer patients. So if we consider what we have in terms of approved HER2 targeted treatments, we have at the moment trastuzumab deruxtecan. This drug has been approved by the European Medicines Agency for patients with advanced non-small cell lung cancer with activating HER2 mutations who require systemic therapy following a previous platinum-based chemotherapy plus or minus immunotherapy. The FDA in the United States has also approved this drug in the same indication in patients with advanced non-small cell lung cancer with activating HER2 mutations. But in addition, very recently, there was a pan-solid tumor approval for patients with advanced HER2 positive, that meaning an immunohistochemistry assay report of IHC3+, following prior systemic therapy and in situations where there is no further alternative satisfactory treatment option. In terms of future directions for HER2-targeted therapy, there are basically two approaches which may be pursued. We're still looking for tyrosine kinase inhibitors and have a variety of drugs in phase 1 and phase 2, as well as in phase 3 trials where zongertinib and pyrotinib are more advanced in the phase 3 setting. As well as trastuzumab deruxtecan, which is an approved antibody drug conjugate, we have other antibody drug conjugates in phase 1 and also in phase 2, where trastuzumab is also being investigated in conjunction with another cytotoxic payload, tansine, and other ADCs are also in the phase 2 treatment space. So, Enriqueta, we now need to turn to some of the questions that our audience have posed in the area of HER2-targeted treatment for our patients with non-small cell lung cancer. And the first question that I have for you is, what do the latest data tell us about a link between HER2 status and patient outcomes with HER2-targeted treatments in non-small cell lung cancer?
Thanks, Keith. So yes, there is new data in patients with HER2 mutations and also HER2 overexpression. I would like to highlight the Destiny Lung 01 trial. In this trial, there were two cohorts of patients with HER2 mutations and also patients with HER2 overexpression. And it was important because in the patients with HER2 mutations and also previously treated with chemotherapy plus minus immunotherapy, so 91 patients were included with this mutation, and the response rate with trastuzumab deruxtecan was 55%. So you mentioned trastuzumab deruxtecan, an antibody drug conjugate. These are new class of agents with a monoclonal antibody targeting HER2, the payload, and also the linker. And you know, this percentage of response is really important. Also in this trial, we have seen that the median duration of response with these ADCs in these patients with HER2 mutations was 9.3 months. Long also progression-free survival, 8.2 months. And importantly, this agent was also active in patients with brain metastases. This was the initial trial. The dose in that study was 6.4 milligrams per kilo. And the next step was the Destiny Lung 02 trial. Again, in these patients with HER2 mutations were included previously treated with chemotherapy plus minus immunotherapy and randomized to two different doses. The dose used in the Destiny Lung 01, 6.4 milligrams per kilo. 50 patients were treated, and also a lower dose of trastuzumab deruxtecan, 5.4 milligrams per kilo. 102 patients were included. We have seen exactly the same response rate between the two treatment arms, around 50%. The median duration of response in the two treatment arms around 12 to 12.5 months, and also a median PFS between 10 to 12 months. So very similar results with the two doses, and this was the dose that is recommended for FDA and EMA is trastuzumab deruxtecan 5.4 milligrams per kilo in patients with HER2 mutations previously treated with chemotherapy. And again, to mention that the patients included in these two trials were patients heavily pretreated, and there were a number of patients with brain metastases. And then the results in patients with HER2 overexpression in the trial, patients with HER2 and HER3 plus were included. And again, there was a comparison between the two doses that I have just mentioned of trastuzumab deruxtecan, 5.4 per kilo and 6.4 per kilo. And again, we have seen the same results, so very similar results between the two doses in patients with HER2 overexpression, lung cancer previously treated, also median duration of response of 6 months, median PFS of around 6 months. No? And again, patients with brain metastases, we observe responses in this group of patients. So antibody-drug conjugates are now, part of the treatment of patients with HER2 mutations in Europe, and also by FDA, patients previously treated. These are patients in second line. There are other investigational agents in this scenario. Trastuzumab emtansine, TDM1, was previously analyzed in patients with HER2 mutations. This is also an ADC, and in patients with HER2 mutations, a 38% response rate was observed with a median duration of response of 3.5 months and a PFS of 2.8 months. And the other class of agents, tyrosine kinase inhibitors, also important. Perhaps the first agent analyzed in patients with HER2 mutations was pirotinib, and this was analyzed in more than 70 patients, again previously treated with HER2 mutations, achieving a response rate of 19% and a median duration of response of 9.9 months and median PFS of 5.6 months. And this year, recently during the ASCO meeting, two new HER2 TKIs that we have seen results. The BA2927088. It was an interesting study presented, including 34 patients with non-small cell lung cancer and HER2 mutations. We understand that it's a small sample size, but in this group, the response rate with this tyrosine kinase inhibitor was 70%, and the median PFS was 8 months. And another one, zongertinib, again presented during the ASCO meeting, 41 patients with HER2 aberration positive, including non-small cell lung cancer patients with 44% response rate. So overall, trastuzumab deruxtecan, that is approved in HER2 mutated patients after chemo and radiotherapy, after chemo and plus minus immunotherapy, and also new TKIs that are now being analyzed in patients with HER2 mutations also previously treated. So we have a number of advances in patients with HER2.
So thanks, Enriqueta, for that great summary. Another question, when should HER2 targeted treatments be utilized in the patient's treatment pathway?
Yeah, thank you, Keith. So yeah, we have also some recommendations from guidelines. So according to the ESMO guidelines and also NCCN, trastuzumab deruxtecan is indicated for those patients with HER2 mutations after prior first-line therapy with chemo plus minus immunotherapy. So this is clear in the two guidelines. Also, ASCO recommend trastuzumab deruxtecan in the second-line setting, and we have trastuzumab emtansine that is also recommended by NCCN. I think now when we discuss the different results, I think we have a strong evidence with trastuzumab deruxtecan in this setting. So I think, in my opinion, this is the preferred one. It's true that now we are analyzing the potential role of this ADC in the first line. So there is one ongoing trial in patients with HER2 mutations, treatment naive, comparing trastuzumab deruxtecan versus standard of care, chemotherapy or chemotherapy plus immunotherapy. So this trial will establish the role of an ADC targeting HER2 in patients with HER2 mutations. And then we have the HER2 overexpression that you have alluded. So probably in the near future, we will need not only the HER2 mutation status, but also the HER2 overexpression to know if the patient has a HER2 a 3+ overexpression. But I think now the situation in lung cancer is clear. Trastuzumab deruxtecan is the treatment that is indicated for patients with HER2 mutations after first-line therapy.
So another important question that always comes up when we're discussing new drugs or new classes of drugs is around side effects. What side effects do we need to consider in patients receiving HER2 targeted therapies for non-small cell lung cancer?
Yes, thank you, Keith. Yeah, managing adverse events is also is also key, and also this multidisciplinary approach, to treating the toxicity. I think we have learned a lot about the management of trastuzumab deruxtecan in patients with lung cancer. The main toxicity that we can expect is GI or hematologic toxicity, nausea, neutropenia, and fatigue. And also we have learned that ILD, interstitial lung disease, is present. It's true that the percentage of patients with ILD is reduced with the lower dose that we have mentioned, the 5.4 milligrams per kilo. But again, it's important to notice that this is a potential toxicity, and we have implemented all the guidelines, algorithms in the institutions in order to react in presence of a potential ILD. We have also discussed trastuzumab emtansine, TDM1. It's true that, as I mentioned, this is not an agent that we use to give to the patients. It's not IMA-approved, but again, this agent is indicated in breast cancer patients, so we know the toxicity, mainly thrombocytopenia, appetite loss, and also it's described interstitial pneumonia. But perhaps it's important also to discuss the toxicities with the tyrosine kinase inhibitors. We don't have any of them approved now, but are in the clinics, and yes, I am seeing in the future a situation in which the patient will receive perhaps first an ADC and then a TKI, and we have pirotinib, that the main toxicity that we need to manage is diarrhea, probably, that it's relevant for the patients. The BAY compound presented at ASCO, again, diarrhea was one of the adverse events in 21% of the cases, vomiting and decreased appetite, and stomatitis, and also the other TKI also presented during the ASCO meeting, thongertinib, also it seems is well tolerated, but we have seen increased ALT, diarrhea, and increased AST. So I think it's important to know the toxicity associated with these agents, and also to work all together, because minimizing adverse events is key for the quality of life of the patients. So I think we have reached the end of this initiative. Thank you for joining this activity on HER2 in non-small cell lung cancer. Thank you for being with us today, and we really hope you have found it interesting.